having me here today, and thanks for your time and attention. I really appreciate it. So I'm going to dive right in. Almost exactly 3 years ago today, I was lying in a hospital bed about to get treated for kidney cancer. At the time, I was working at a leading healthcare usability and innovation consultancy, which you may have heard of, called Healthcare Human Factors. And we were engaged in a lot of different projects, including some great cancer innovation work. But what I saw on the other side of the gurney was pretty eye-opening. And despite our hard work trying to create kind of groundbreaking, innovative products and services, and amongst other people around the world working on these problems too, the end-to-end patient experience had a lot of holes in it, or at least what I experienced. And especially before the time that picture was taken, when I was in hospital. Now, reflecting on my time as an active cancer patient, I realized that a big part of the problem was that my interactions with the healthcare providers and the system in general were really sporadic and very brief. In total, once I added it all up, being a designer, I went back and did kind of a time study and realized that less than 1% of my waking hours as a patient was spent in direct contact with providers. And so that meant that I was left fending for myself for over 99% of the time. So it was just me as a first-time newly diagnosed cancer patient with my friends, family, and Dr. Google. So as you might imagine, I had a ton of questions, fears, and endless unknowns. And at the same time, from the system perspective, this also meant that the providers, my doctors, nurses, didn't know what was happening with me for the vast majority of the time. And now this wasn't their fault, it's just kind of how the system has operated for years. So regardless of the cause, this is like a massive opportunity, or I see it as a massive opportunity to improve the patient experience and for the system to learn about the patient throughout the continuum of care so that we can provide more responsive and supportive services as the patient actually needs them. Because you can imagine that issues and symptoms don't magically arise just before a scheduled visit or during a scheduled visit. And so a typical response to challenges in healthcare is this idea that technology will save us. In academic medicine specifically, it often looks like one of two things. One, kind of a bespoke pilot where new technology is introduced and put into a randomized controlled trial. And then at the end, publish the results, talk about it at our conference, but there's not really a clean or clear way to sustain or scale that innovation. And second is a long RFE process to procure a big monolithic installation of a new EMR or a big piece of software or IT. But those rarely live up to the kind of all-in-one dream that the sales pitches promote. But so this leads us to another approach that has been used, that we're using specifically, and it's something that's really embracing a more fluid or agile mindset towards service innovation. So it really focuses on the clinical workflows and the end-to-end patient journey first, building new care models, and then, only then, bringing in modular technology as it's needed. And then, of course, iterating with the clinical teams and the patients and whoever's involved in the field with the express intent of scaling that innovation throughout the organization. And so for a couple of years ago, after I was deemed cancer-free, thankfully, I partnered up with Ali Berlin, a radiation oncologist, And with the support of the previous head of the cancer center at the time, Mary Gosperovitz, we actually launched a new innovation program called Smart Cancer Care, and really trying to bring a mix of clinicians, designers, technologists, informaticists, researchers, engineers, patients, providers to collectively bring this new creative problem-solving method and really a new mindset into the cancer center. And so quickly, I'm going to highlight a few different projects as case studies to kind of illustrate how we've applied this fluid, agile service design approach to healthcare innovation. And hopefully we can run through it quickly so that we save a lot of time for questions. So we kind of got to work in earnest when COVID hit. So we really dove into action, aiming to help virtualize PM, or Princess Margaret. And so we had the goal, one of our leaders at UHN had the goal that 50% of outpatient visits would be converted to virtual. And so we were, successful and kind of lucky that we were starting from scratch. Princess Margaret did almost no virtual visits before the pandemic. And so we were able to shift like a massive proportion. I think we got over 50% within a couple of weeks and moved up to almost 70%, within that first month. And the point of this work was, not to implement something, cool new tech. It was to spare immunocompromised cancer patients from unnecessary visits, while at the same time maintaining continuity of care during this like really stressful, uncertain times of the early pandemic. And so working in the way that we did with all of our partners, we were able to keep up capacity and actually even increase it. And this really began our work as this new team, Smart Cancer Care, and really laid the groundwork for our new way of working. And so the thing that we actually did in this case was we created a product or a system called Virtual Care Management System, which is an enterprise software kind of system that allowed providers, cancer care providers, to rapidly review and prioritize thousands of cancer patients who have been booked for visits before the pandemic hit, but then a lot of those had to be switched into virtual care or have their appointment pushed out, or for the acute, really critical cases, retain their visits in person. Now, had we just left everyone to their own devices, this would have taken hours and days to figure out how to do this, rebooking, to review everyone's chart one by one, determine whether people were, should be seen immediately or deferred or brought in virtual. And then that would have introduced a lot of safety risks in communicating all of this and doing all that work. And so we built this system in part to allow this to be done really efficiently, and within an hour, a clinician could review all of their cases and decide how to proceed and start the rebooking process. And we also built into the same system the ability to enter orders digitally, which on the face of you might be saying, wow, orders were still done on paper before this. And yes, unfortunately, that is the case. It was the case. And so we created a digital order system, which kind of effectively plugged another major safety gap, where, if you can imagine during the early pandemic, people were remote, like physicians, nurses, administrative folks, and patients were all distributed. So if a physician wrote out orders on a piece of paper, there was not necessarily a human to hand that off to, which was the case before. And so the risk was that these papers would get lost or put in the mail or be left on a desk and be unattended for days or weeks, putting the patient at risk. And so this was another kind of added feature that we went through you know, and the big kind of story here is not that we introduced this software that, if you look at it, it doesn't look very sexy. It's pretty basic, but it plugged a lot of holes and added some real streamlined efficiencies in this like really hectic time. And the big win was that we introduced this technology quickly, like within days. How often do you hear of like an IT implementation in the hospital that's happens in days? And so we knew that our systems weren't perfect or finished, and so we continuously iterated on the model, on the software, ingesting feedback and different requests from patients and providers throughout thousands of experience surveys and dozens of qualitative interviews and showing up at staff meetings. And so as we added a bunch of new features and introduced some trending and symptom tracking and alerts over time. And so the service continued to get better and better. Now, so what we really care about in this work isn't the technology. Again, this doesn't look like great, amazing tech, but this was fast, quick, and dirty, and it worked. But we really care about the workflows and the patient experience. And so with at UHN, we're introducing a new HIS, or a new electronic medical record, which will take the place of a lot of this work. And so we're totally happy to pass that along. And so new tech will be swapped in, our workflows will be maintained, and hopefully the patient journey will again be retained and improved. And so we don't really care about the technology so much. We care about workflows and patient experience. Now, the next case is this virtual nurse-led clinic, proactive nurse call clinic, which was to meet the needs of patients who had the double burden of having cancer and testing positive for COVID. So we worked with, the whole team, nurses, educators, docs, infection control, et cetera, to streamline screening, alerting, and this vast amount of complicated documentation and communication within the hospital and outside the hospital, again, for pandemic. And so ultimately, we created a service that involved nurses calling COVID positive cancer patients to routinely check on them and their COVID and cancer symptoms to ensure that, they weren't deteriorating. And so we were going above and beyond for our most valuable patients. And for this program, again, similar to the last one, we kind of stitched together a bunch of different systems, the lab system, scheduling, alerting the patient records, working with public health, and the usual Outlook inbox or email system that we have at UHN, to ensure that we could launch this quickly and with minimal new systems, so that we could do minimal onboarding to clinicians, so that they were kind of used to working with all of this. And so it's shown here, it's not shown here, but we had like an incredibly high satisfaction rate with patients, and actually recently won a quality award from the Cancer Quality Council of Ontario. Okay, the last case. So this is talking about PATH. So PATH loosely stands for Princess Margaret at Home. So again, this is a pandemic-inspired opportunity that opened up as patient symptoms were previously collected in the wait room on iPads to help for screening for serious issues and to help guide the visit. But they were removed, the iPads were removed to minimize infection risk. And so to fill that gap and restart this program after COVID hit, because it was a provincial requirement, we quickly launched a web survey tool to collect symptom data from our patients from home. And so we rapidly deployed this across the entire organization for every cancer patient who had an email on file. And you can see here that we're tracking all sorts of things at different clinics and over time to see how we're doing and to really direct more investigation efforts and to kind of leverage the data to do micro changes in real time to improve this service for all the people who are using it, the patients and providers. And so this kind of stuff, like being really data driven and being using really granular kind of user data is commonplace in kind of all other digitally informed industries, but for some reason it's not quite the norm in healthcare. But that's part of the way that we're able to be really kind of nimble and agile. And now we're using that initial build, that initial platform to solve some long-standing non-COVID issues that were around affecting how patients can flag how they're doing at any time throughout their cancer journey, whether it's a symptom, a concern, or a simple request like that they need an insurance form or a new prescription refilled. Currently, between visits, patients had one of three options. One, suck it up to the next visit. Two, go to the emergency department, which is not ideal for anyone right now, let alone a cancer patient. Or three, call this overburdened, kind of antiquated, convoluted triage line, which is basically results in leaving a voicemail on an old school answering machine and hoping to get a response back, which was a really bad experience for patients and also for staff because it's super inefficient, it's poor transparency, and it's not clear what the volumes were like or what the wait times were like. And so this was like a big potential issue with patients if they had like a serious side effect. And so what we're doing later this month is launching a tool that we're internally calling a digital triage line, which is really a one-stop shop to allow patients to enter any concerns, symptoms, requests when and wherever they have it into this single portal, which will then be automatically prioritized and triaged and passed to the right person, whether that's currently a nurse or an admin staff. And in the future, we're building in social work and other supportive care providers. And so we're launching this as a pilot in the palliative care clinic next month. And we're doing so with the explicit desire to scale this, if successful, across the entire hospital. And so in parallel with this launch, we're working on mapping other clinics and really understanding the workflows and the needs of other clinical scenarios. So in summary, this is kind of a busy slide, but what we've been using is what we think of somewhat a novel approach to this kind of work, and it's starting to bear fruit for us. It's a bit of a different mindset, but it does use similar methods that you're used to, like in the last talk, the double diamond or the triple diamond. That's the same stuff, the same kind of methods, but maybe a slightly different mindset than traditional kind of product design, where we're like dedicating solving for the entire patient journey. And we're like in the process, we're breaking down silos wherever possible. And ultimately, I hope that this style of working can transition our cancer care and ultimately maybe our entire healthcare system into a new era where fluid or agile service innovation that optimizes the patient and provider experience is the new norm. Yeah, and I guess I kind of put this out to you. You guys are the next generation of healthcare innovators. And so hopefully this was useful to weave into your work and your future work, and love to discuss more now. So if anyone has any questions, happy to chat.
Great, thank you, Mike. That's quite a story. To get our short Q&A period here started, 12 days is a very short period to launch kind of a new platform. How was that all like, especially you know, with the chaos of the pandemic being announced and everything?
Yeah, you know what, it was so I've worked in healthcare for a long time. It was actually refreshingly straightforward. It was hard and stressful, but we were just full tilt. and everyone on our team and then the wider, UHN was kind of aligned with this common goal. And our leadership was very aligned and on board. And so it was kind of this interesting world that we entered, where kind of like you asked for it. If you were kind of pointing in this direction, getting patients into virtual care, people just kind of open the doors to it, as opposed to the kind of typical, run around like, no, slow down, go talk to this other person. People were just like, how can we help? So it was actually really, really exciting, and things were really smooth.
That's amazing that everyone rallied together. Do we have any questions in the chat or from any other of the exec?
I have a question. Do you foresee in the future similar it seems like these were very unique circumstances, the circumstances of COVID that enabled you to get this platform up and running in 12 days. Do you foresee in the future the ability to do something so quickly again?
So, yes. I mean, we're really leveraging the momentum of the pandemic and this kind of, yes, we can, let's figure it out solution kind of attitude. We're trying to continue that going forward, and we're like using this language to kind of coax people along so that we don't slump back into the old ways. And so I have seen this momentum carry on. We've done there's a whole other arm of our work that has been launched since the pandemic, and so far it's been going smooth. I think one thing that we're really struggling with now is burnout and clinicians who are like nurses, for instance. We're really short on nurses, and so that's where the kind of barriers seem to be right now, as opposed to this just fear of technology. But yeah, we're trying to keep the momentum up.
And what about uptake? Has it, especially as you try to, as you've mentioned in the last part of your presentation, expanding, that can always be a bit of a challenge, introducing a new system or a new way of doing things. Yeah,
I would say, there's a lot of change happening at UHN specifically right now. So we're getting a new HIS in the next 8 months. And so people are very cautious that and stressed now that they're getting a lot of change. But yeah, I feel like if you start, in our experience, if you are working in a small group, so a small group of clinicians with, lots of multi-disc collaboration, it tends to actually elevate people. For whatever reason, we're a young group that's like excited to change things. And we found that all the partners that we work with are also get excited about doing this work. And so our kind of approach is do small pilot. Again, I said this before, but do small pilots, but with the express intent of like scaling or spreading our kind of innovations to other sites. And so we get the momentum going, we get the buy-in, we get the data, we iterate, and then we can kind of sell that to the next group that we work with and have the buy-in, because the clinicians are actually excited about the change.
Nice. I guess kind of related to that, and I think time for this last question from Wenchao in the chat. Any plan to test this in the US healthcare market?
In short, not right now. We're like really focused on kind of changing the way that things are done at Princess Margaret, with kind of ripple effects to hopefully to Ontario and Canada. We are like open to having conversations about things in the States, but that's not kind of our core focus right now.